So without wasting more time, we'll kick off with Dr. Santi Trimarchi, and I have the pleasure of introducing Dr. Trimarchi, who works in San Donito Cardiovascular Center. He's been attending there since 1997. He has a special interest in aortic dissections and is associated with the ARAD database and has published extensively on its behalf. And this presentation itself is based on the ARAD database. So Dr. Trimarchi, please.
Thank you very much, dear moderators, dear colleagues. First of all, thanks so much for this important organization for inviting me. Giving this talk means an IRAD perspective about reoperation after type A dissection. So probably, as you know, IRAD is an observational registry who was established in 1996 by three principal co-investigators. Dr. Ninaber today is in this room, in addition to Dr. Eagle and Dr. Isselbacher. So after almost 19 years from since its beginning, this registry has been able to publish over than 70 manuscripts. Actually, there are 38 active sites and also additional centers who are interested in joining the program. And actually, we have almost 70 active projects ongoing. The topics today, talking about reinterventions, would consider in particular what happens in the proximal aorta, distal aorta, and also if we have some predictors of subsequent intervention after the initial treatment for type A. So let's have a look first about what happens in the proximal aorta. IRAD had the opportunity to publish recently a paper by Dr. Dieusanio and other colleagues where we compared the root repair, which include both ventral procedure and valve sparing procedure, versus those patients who had the conservative root management. We saw that these patients who had root procedure were younger, but of course they have more frequently aortic valve disease and bicuspid valve disease. In addition, this patient, of course, had more frequently a Marfan syndrome. Less frequently, those patients with the root management presented with intramural hematoma. Of course, this is easy to understand. They more frequently had also an aortic root dissection and presented with more frequently with aortic regurgitation, coronary involvement, and also with larger root and ascending aortic diameter. It was interesting to note in this work that actually European sites showed a significant increase in managed root during type A dissection with ventral or valve sparing procedure compared to US where this change was not shown. If we look into the surgical procedure that this patient had, we noted that those had also more frequent complete arch replacement, and this was, of course, associated with the longer pump time and the longer myocardial ischemic time. In terms of mortality, you can see that those patients with conservative root management had a slight reduced mortality compared to those with the root management. And also the multivariate analysis, this showed that the root management was not a predictor of in-hospital mortality in such patients, as you can see over here. At the 3 years follow-up, IRAD data showed that the conservative root management was not associated with the reduced mortality and even was not associated with the reduced freedom from redo operation. We try also to compare the IRAD data with the previous experience. This is an historical paper published by the Stanford group. You can see 82 patients which were managed with conservative root management had a 6 years freedom from proximal reoperation at the range of at the percentage of over 95% of the cases. And also this paper showed from Dr. Kuchuko's group that different proximal or distal surgical strategies in such context did not affect aortic growth or need for reoperations. More recently, some experience that focuses on imaging-based study, they showed a relative high risk of progressive aortic disease in those patients who had a conservative route management. However, they did not show decreased survival or decreased freedom from reoperation. The second point that we want to point out is related to the extension of arch repair in type A dissection. The previous paper that I just mentioned showed that complete arch replacement is associated in the IRAD group with increased in-hospital mortality. This is another unpublished IRAD experience. We took in consideration more than 500 patients comparing those with limited versus extended arch repair. You can see that mortality as a trend for being higher for those patients treated with extensive arch repair. So arch replacement seems to be related to an increase in hospital mortality, but this is not significant as other clinical and surgical details can be shown, as previous cardiac surgery, as presence of coma, as presence of preoperative hypertension, shock, or tamponated admission, as a necessity to perform a concomitant CABG during the procedure, which is associated also with the longer pump time. Arch replacement per se is not really important predictor of in-hospital mortality in this second cohort that we just showed, and also the Kaplan-Meier at 5 years follow-up did not show an increased risk for aortic mortality or aortic events, as you can see over here. As we did, and another point of interest was that we noted a trend for increasing arch total repair in these patients managed for type A dissection over these 19 years of IRAD experience. As we did for the first topic, we tried to compare the IRAD data with previous experience. This is a Yale experience which show, this is experience from UPenn, from Dr. Gerson. In Bavaria, you can say that AMI arch repair in this cohort was performed in 97% of the group. At the 5 years follow-up showed that more than 85% of these patients had freedom from aortic reoperation. Another important experience compared those patients affected by type A dissection treated with frozen elephant trunk or aortic or right AMI arch repair. You can see that those patients with the frozen elephant trunk had their better long-term results in terms of survival and also freedom from reoperation. This is another experience, but another experience who comes also from Far East did not show the same results. This is Dr. Sun results for those patients treated in the acute and chronic setting with frozen elephant trunk, although the in-hospital results looks excellent, and the conclusion of their paper say that such encouraging surgical results are promising, and probably we should go forward with a new standard technique for treating such patients with a frozen elephant trunk. They were not able to evidence significant difference in terms of long-term freedom from reoperation, both for those patients treated in the acute setting and for those treated in the chronic setting. And this is another paper who comes from an Italian group who showed similar results in terms of freedom from reoperation after management for type A dissection. And we move to the third point, which are the predictors of subsequent intervention after initial treatment for type A dissection. Also, in this case, we are mentioning some unpublished data. We took in consideration only those patients who presented with the follow-up. So on 470 patients affected by type A dissection, we noted that the predictors for intervention were younger patients, patients affected by connective tissue disease, in particular Marfan syndrome, or those patients who had previous cardiac intervention at initial operation. If we look into other experience, we saw similar results from UPenn group. Also, age was a predictor of reintervention as well as longer extension of the dissection. And the other Italian paper reported also presence of false lumen thrombosis is result as predictor of reintervention in their group, as well preservation of native aortic root. So, and the last point for the IRAD data reports that such risk for longer freedom from reoperation is better for type A compared to those patients affected by type B dissection. Means for those patients with B dissection, the freedom from reoperation is reduced, is smaller compared to A. So in conclusion, if we look again into our purpose of reintervention following type A dissection, we may say that if we consider the proximal aorta, conservative root is not associated, at least at 3 years follow-up, with reduced survival or freedom from reoperation. Root repair is more frequently indicated in young patients, for sure in those affected by connective tissue disorders, and aggressive root management may be determined by patient-specific and dissection-related factor. About the second point, about the arch extension, we may say that in type A dissection, extended arch replacement presents similar mortality compared with those treated only with ascending aortic repair. But whether extended arch replacement improved prognosis after 5 years remains to be determined. And about the last point, about the predictors of subsequent intervention after initial treatment for type A dissection, younger age and Marfan syndrome looks the most important subsequent predictors for intervention. Thank you very much for your attention.
Thank you. So we've got a couple of minutes for questions. So just to kick off while people are gathering their thoughts, do you think for the trainees in this room it's a reasonable take-home message that be conservative and safe? Is that a good message to take away from this, you think, from the data you have?
We move from the data to personal opinions. Of course, we face with very different type of population. We have young patients who, of course, may have extensive surgical procedure, both proximally and distally. If we talk about distally, now we have a frozen elephant trunk technique, which is associated with pretty good results. But at the same time, we are facing, in particular in the last 5 years, with an older population among those affected by type A dissection. So do we have to have an extended arch repair in all patients with the frozen elephant trunk? Probably the answer is not, because we have a longer pump time, because it's related, as always, to the surgeons who are on call in that moment. So someone are able to treat this patient in somewhere and some others no. So probably a more specific patient's approach is the way to follow in these cases.
Okay, if we don't have any more questions from the audience, thank you very much, Dr. Trimarchi. And